Hello, I'm David Grenache. I'm an associate professor of pathology at the University of Utah and a medical director at ARUP Laboratories. And I wanted to speak briefly today about risk stratification in heart failure and the role of emerging biomarkers. So heart failure is a complex clinical syndrome that can result from any structural or functional cardiac disorder that impairs the ability of the heart's ventricles to fill with or eject blood. Because the heart is unable to meet the body's circulatory demands, common signs and symptoms include shortness of breath, fatigue, and edema. The most common causes of heart failure in the United States include coronary artery diseases such as myocardial infarction, hypertension, and diabetes. Heart failure is one of the most rapidly increasing cardiovascular disorders worldwide. The global burden of heart failure is about 20 million people, 5.1 million of which are in the United States, which sees approximately 825,000 new cases each year. The prognosis for individuals with heart failure is generally poor and results in reduced physical and mental health. Sadly, about 50% of people with heart failure die within 5 years of their diagnosis. Each year in the United States, heart failure accounts for more than 1 million hospitalizations, more than 3 million physician office visits, 57,000 deaths, and an estimated $32 billion in healthcare costs. Heart failure is also the most common cause of hospital readmissions, with 20% of patients readmitted to the hospital within 30 days of discharge and nearly 35% readmitted within 90 days. Numbers such as these has prompted CMS to make heart failure one of the targets for new initiatives to reduce these numbers and cut Medicare costs. Heart failure is staged according to the American College of Cardiology, American Heart Association guidelines. Additionally, a patient's functional status can be classified according to the New York Heart Association classification. And as can be seen here in this table, there is considerable overlap between heart failure stage, shown on the left, and New York Heart Association classification of symptoms, shown on the right. Also, the stages of heart failure are progressive and inviolate. Once a patient moves to a higher stage, regression to an earlier stage of heart failure is not observed. And as you would expect, progression in heart failure stages is associated with reduced 5-year survival. So how can biomarkers help patients with heart failure? Well, there are two potential roles. First, biomarkers can help predict who is at risk for adverse events. And second, they can identify patients who need interventions to prevent hospital readmission. There are several heart failure biomarkers. Some have well-established clinical utility, while others are still in preclinical stages of investigation. Markers such as the natriuretic peptides, cardiac troponins, and oxidative stress markers are increased in response to myocardial insult. And while they are excellent indicators of cardiac pathology, they often peak after substantial progression of disease. Biomarkers that respond to neurohormonal activation, such as the renin-angiotensin system, norepinephrine, and arginine vasopressin, are well-established markers of cardiac distress. However, many of these biomarkers are also elevated in other conditions that involve sympathetic nervous system or kidney dysfunction. And lastly, there are the biomarkers of maladaptive remodeling. Many of these markers are nonspecific indicators of inflammation, while others are involved in hypertrophy and remodeling. Two emerging biomarkers of cardiac fibrosis are soluble ST2 and galectin-3, and these are the two biomarkers that I want to focus on today. ST2 is a member of the interleukin-1 receptor family, which was originally shown to be involved in inflammatory processes and immune tolerance. It exists in two isoforms, membrane-bound ST2 ligand and a soluble form that's not anchored to the cell membrane. The ligand for ST2 is interleukin-33, a cytokine secreted by stretched cardiac fibroblasts and myocytes. When interleukin-33 binds to membrane-bound ST2, it helps to prevent myocardial hypertrophy and fibrosis. The soluble ST2 isoform functions as a decoy receptor, preventing the biological action of interleukin-33. As such, serum concentrations of soluble ST2 are correlated with structural and functional cardiac changes consistent with remodeling in patients with heart failure. Studies have shown that soluble ST2 is a prognostic indicator of short and long-term mortality. Shown on the left are results from an early study of 593 patients with acute shortness of breath with and without heart failure. And you can see the short-term prognostic meaning of soluble ST2 was considerable. Concentrations of the marker were highest in patients who were dead at 1 year compared with survivors. The right figure shows that patients with heart failure, in the top, panel A, and in those without heart failure but with shortness of breath, in the lower panel, panel B, that had elevated soluble ST2 concentrations had rates of death that rose rapidly from enrollment and continued to rise at 1 year. Similarly, elevated concentrations of soluble ST2 also predicted incrementally higher risk of death at 4 years in 134 dyspneic patients with and without decompensated heart failure. Combining soluble ST2 with NT-proBNP was shown to improve the prognostic ability of either marker alone, such that elevations in both markers were associated with the highest risk of death in patients with shortness of breath, that's the top panel shown, with and without heart failure, as well as those with acute heart failure, shown in panel B, at 1 year. Also, patients with chronic heart failure at 3 years were shown with higher concentrations of both ST2 and NT-proBNP were shown to be at higher risk of death. Recently, soluble ST2 was shown to have potential utility to identify chronic heart failure patients who may benefit from higher doses of beta blockers. Patients with low soluble ST2 titrated to high-dose beta blocker had the lowest rate of cardiovascular events compared to those with either low soluble ST2 and low beta blocker dose or high soluble ST2 and high beta blocker dose. Patients with high ST2 treated with the low dose of beta blocker had the highest rate of cardiovascular events. When measured serially, soluble ST2 may predict patients at greater risk of death. As shown by a study of 150 patients with acute heart failure followed by 90 days, those who had values that decreased by 15.5% or more during the study period had a 7% chance of death, whereas those who had SST2 levels that failed to decrease by less than 15.5% had a 33% chance of dying. Galectin-3 is another emerging biomarker that is implicated in cardiac remodeling, which occurs in response to acute insults such as acute myocardial infarction and cardiomyopathies, and can lead to chronic heart failure. Galectin-3 is a beta-galactosidase binding lectin expressed and secreted by macrophages in response to cardiac injury. Galectin-3 causes the proliferation of cardiac fibroblasts that then deposit type 1 collagen, leading to scar formation, cardiac remodeling, and dilatation. As has been seen with soluble ST2, elevated concentrations of galectin-3 was associated with an increased risk of short-term death, shown here on the left, in 209 patients with acute heart failure. Also, like soluble ST2, a multi-marker strategy combining galectin-3 and NT-pro-terminal BNP provided complementary and superior risk discrimination relative to either marker alone. As shown on the right, the top panel shows the risk of death was greatest in those with elevated galectin-3 and NT-proBNP, while the bottom panel shows similar results when death and heart failure readmission were combined. Likewise, increased concentrations of galectin-3 predicted increased risk of adverse outcomes in 248 patients with chronic heart failure. The left panel shows the cumulative incidence of death or rehospitalization, and the right panel shows the cumulative incidence of rehospitalization alone. It is well known that patients who develop acute coronary syndrome have a significantly increased risk of developing subsequent heart failure. A recent study of 100 ACS patients who were followed for 2 years reported that the increased concentrations of galectin-3 are associated with the risk of developing heart failure. Those with the highest concentrations had nearly 4 times the risk of developing heart failure than those with the lowest concentrations. Like soluble ST2, serial testing for galectin-3 might also predict patients who are at risk for adverse outcomes. Data from 2 large prospective trials showed that increases in galectin-3, defined as a 15% change from baseline, was associated with a significantly greater hazard of heart failure hospitalization or death. Last year, the American College of Cardiology Foundation and the American Heart Association published updated guidelines for the management of heart failure. They gave a Class 2B recommendation that myocardial fibrosis markers, such as soluble ST2 and galectin-3, may be considered for additive risk stratification in ambulatory and acute heart failure patients. So in summary, soluble ST2 and galectin-3 are new and emerging biomarkers of maladaptive remodeling in heart failure. Elevated concentrations of soluble ST2 and galectin-3 are associated with increased cardiac fibrosis and increased risk of death and rehospitalization. I've shown that soluble ST2 and galectin-3 can provide information that is independent and complementary to that of the natriuretic peptides. And while the optimal use of soluble ST2 and galectin-3 in managing heart failure patients is still emerging and uncertain, it continues to be an area of ongoing and active investigation. Thank you.